physiotherapy techniques in infants and children. Most physiotherapy techniques used in adults can be applied in children, and the same contraindications apply. The possible deleterious effects of chest physiotherapy and suction mean that treatment should only be given when indicated and never as a routine. Treatment should be performed prior to feeds or at least 1 hour following feeds to avoid the potential for aspiration of stomach contents. Chest percussion. Chest percussion includes chest clapping using the hand or a face mask. It is generally well tolerated and can be extremely effective in the young child. Clapping should be one-handed in small children and infants. For preterm infants, the first 3 or 4 fingers of one hand may be used, slightly elevating the middle finger, tenting. Chest percussion can be applied using a cup-shaped object such as face mask. This mask has a soft plastic cuff and so can be used over bare skin. The face mask has been shown to be a well-tolerated means of percussion in the preterm infant. Position of fingers for tenting, percussion with mask. Vibration and shaking. The chest wall is very compliant in infants and young children, so vibrations can be very effective in removing secretions when the respiratory rate is normal or near normal, 30 to 40 breaths per minute. In infants, if infants are breathing very rapidly, example more than 60 breaths per minute, the expiratory phase is so short that vibrations are neither easy to apply nor effective. Percussions for chest percussion and precautions for chest percussion and vibratory techniques. Children with dietary deficiencies, liver disease, or those who have been born preterm may develop rickets. Skeletal changes in rickets include general osteoporosis and softening of long bones and deformities of the thorax and pelvis. In these circumstances, percussion and vibrations may be contraindicated. Very preterm infants have extremely thin skin, which is easily bruised and damaged, thereby predisposing to infection. Chest percussion and vibrations may not be appropriate in these infants. Bronchospasm may be exacerbated by the use of chest percussion. Pre-medication with bronchodilator therapy is essential, and it may be advisable to avoid percussion in some cases. Gravity-assisted positioning, postural drainage. Gravity-assisted positioning can be used for children in the same way as for adults. The upper lobes, particularly the right side, are often more affected by respiratory problems in younger children, so gravity-assisted positions for these areas are important, particularly the posterior segments. A head-down tip should be avoided in children with raised intracranial pressure and in preterm infants who are at risk of periventricular hemorrhage. This position should also be avoided in infants and children with abdominal distension, as this places the diaphragm at a mechanical disadvantage. Care should be taken in infants with a history of reflux. Whether the tipped head down position should be used in infants with reflux remains unclear. Some evidence exists suggesting that its use may aggravate reflux and possible aspiration, while other reports state that this position has little effect on reflux. Reflux is particularly common in preterm infants, affecting approximately 80%. Positioning. Careful positioning is important to optimize lung function, and supine is the least beneficial position. Prone has shown to be advantageous in preterm in terms of respiratory function, gastroesophageal reflex, and energy expenditure, and should be used in infants with respiratory distress who are being closely monitored. However, parents should be advised against this position when babies are sleeping unattended because of its association with sudden infant death. Owing to the differences in regional ventilation, care should be taken when positioning an affected lung segment, lobe uppermost, as this may cause rapid deterioration of respiratory status in the acutely ill child. Newborn infants are better oxygenated when tilted slightly head up and show a drop in PaO2 if placed flat or tilted head down unless they are fully mechanically ventilated. Manual hyperinflation. The same indication and contraindication apply for children as for adults when considering manual hyperinflation as a physiotherapy technique. 500 ml bags are used for infants, 1 liter bags are used for children. Bags may have valves or be open ended for outlet of excess pressure controlled by the operator's fingers. A manometer should be placed in the circuit whenever possible to monitor the inflation pressures being generated. As a general guideline, the inspiratory pressure should be increased from the ventilator pressure by no more than 5 cm H2O in an infant and 10 cm H2O in an older child. In order to prevent airway collapse, some positive end expiratory pressure PEEP should be maintained in the bag whenever possible. Self-inflating bags may be used in some units. The flow rate of gas is adjusted according to the size of the child, 41 per minute for infants, increasing to 81 per minute for children. In situations where pulmonary blood flow is very high, it is usually not advisable to use an FiO2 of 1.0 during manual hyperinflation, as this may further increase blood flow to the lungs. Manual hyperinflation should be carried out in children by staff experienced in its use. Precautions of manual hyperinflation in children. The lack of collateral ventilation means that air may not diffuse from inflated to collapsed alveoli, as air under positive pressure takes the path of least resistance. Manual hyperinflation may therefore over distant areas already inflated but leave other areas collapsed. This increases the risk of pneumothorax, and particular care should be taken in conditions causing hyperinflation, example asthma and bronchiolitis. Manual hyperinflation should not be used as a physiotherapy technique in preterm infants whose delicate lung tissue is easily damaged by high inflation pressures. Breathing exercises. Laughing and crying are very effective means of lung expansion in infants. It is possible to encourage children to deep breath from about 2 years of age by using bubbles, paper windmills, etc., although whether these deep breaths are effective is debatable. Incentive spirometers may be useful pre and post operatively when early mobilization is not possible, or when teaching inhaler technique. Huffing can also be introduced at this stage. Older children can be taught the active cycle of breathing techniques. Since children use the diaphragm as the main inspiratory muscle, they find breathing control very easy. Encouraging them to fill up their tummy with air like a balloon works well, provided they are reminded not to use their abdominal muscles. Hyperinflation in small child showing pressure gauge in circuit. Coughing. Children from 18 months of age can often mimic coughing if asked to do so, but it is often very difficult to persuade an acutely ill child to cough and expectorate. Positioning or movement may cause mobilization of secretions which may stimulate a cough reflex. Secretions produced will be swallowed, as the ability to expectorate does not often develop before 3 to 4 years of age. In children of less than 18 months of age, tracheal compression can be used to stimulate a cough. Gentle pressure with a sideways motion is briefly applied with the finger trachea below the thyroid cartilage. This causes a position of the tracheal walls, which are soft and pliant in this age group. Stimulating the cough reflex, this technique must be used with care and only in experienced hands, as the infant can become bradycardic. If there is no effective cough and there are copious secretions, airway suction may be necessary. Airway suction. This topic is also discussed in chapter 8 and 11. However, particular points to note when performing airway suction in infants and young children are as follows. Pre-oxygenation is usually important to reduce hypoxia, but care should be taken in preterm infants to avoid hyperoxia. The inspired oxygen should therefore only be increased by 10% in these infants. Hyperoxia even for a short time, may lead to retinopathy of prematurity. Infants are at particular risk of infection, so great care must be taken with hand washing and wearing gloves, etc. The vacuum pressure should not be excessive but will need to be strong enough to draw secretions up every narrow bore catheters. Recommended values are 10 to 20 kPa, 75 to 150 mmHg. Most commonly used catheters are 6 and 8 French gauge, size F 5 French gauge, and below are usually ineffective in removing thick secretions. Size 10 Fg and above should be reserved for use with older children. When suctioning artificial airways, the external diameter of the catheter should not exceed 50% of the internal diameter of the airway. The diluents and mucolytics, example saline in aliquots of 0.5 ml preterm infant to 5 ml, may be used to enhance secretion clearance. The efficacy of these is not conclusively proven and they should never be used routinely. Larger quantities of irrigants are sometimes used as part of bronchoalveolar lavage procedures, but this should only be undertaken by experienced personnel with great caution. Pneumothorax due to direct perforation of a segmental bronchus by a suction catheter has been reported in intubated preterm infants. In this group of patients, suction catheters should not be passed further than 1 centimeter below the tip of the endotracheal tube. Graduated catheters with centimeter markings are available, or a measured catheter can be attached to the incubator so that staff can gauge how far to pass the catheter. The non-intubated child requiring nasopharyngeal suction should be wrapped in a blanket or held firmly by an assistant to avoid unnecessary struggling. The child should be positioned and sidelined to avoid aspiration of gastric contents. Constant reassurance should be given throughout the procedure. Supplemental oxygenation and resuscitation equipment should be available. Particular care should be taken with nasopharyngeal suction of neonates as reflex bradycardia and apnea can occur. Nasopharyngeal suction should be avoided if the child has stridor or has recently been extubated, as it may precipitate large nasospasm. Passive movements, passive movements and two joint muscle stretches should be given regularly to older children in intensive care. Although they are at less risk of developing joint stiffness than adults, care should be taken when handling children and infants who are hypertonic in order to avoid soft tissue damage. Preterm infants are hypertonic and require minimal handling, so passive movements are not usually indicated. Management of acutely ill infant or child. Respiratory failure in acutely ill infants and children may result from many different medical problems. In the neonate, the most common causes are prematurity, respiratory distress syndrome, asphyxia, and aspiration pneumonia. Under 2 years of age, bronchopneumonia, bronchiolitis, or status asthmaticus, croup, foreign body inhalation, and congenital heart anomalies are more common etiologies. In children over 2 years, asthma, central nervous system infection, example meningitis, and trauma are more frequent. Equipment used in neonatal and pediatric intensive care. Physiotherapists working in an intensive care unit should be familiar with equipment used on that unit. They should be able to respond when a problem is indicated by the equipment and be able to ascertain whether the problem is with the patient or the machine. Incubators and radiant warmers. Infants may have difficulty maintaining their temperature, especially if they were born preterm. They are therefore nursed in incubators or under radiant warmers. Incubators are closed units of transparent material with portholes in the sides for access. They can be warmed and humidified. Air or oxygen can be delivered to the infant inside. The temperature inside an incubator is maintained in the thermo-neutral range, which is environmental temperature at which oxygen consumption is minimal in the presence of a normal body temperature. This will vary according to the patient's gestation and weight. A radiant warmer is an open-topped unit with a radiant heating device above it. It allows free access to the infant, but there is more convective heat loss and insensible fluid loss than with an incubator. Phototherapy unit. These units consist of white or blue lamps which emit light of wavelength 400 to 500 nanometer. Light of these wavelengths oxidizes unconjugated bilirubin into harmless derivatives and so is very important in the treatment of jaundice in neonates. Infants receiving phototherapy have to be nursed naked, which can also cause problems of temperature control. There is increased insensible fluid loss and theoretical risk of eye damage, so eye shields should be worn. Equipment used in pediatric intensive care. Figure shows an infant undergoing extracorporeal membrane oxygenation and high frequency oscillatory ventilation. Electrocardiogram, ECG, respiratory and blood pressure monitors. These are similar to the monitors used in adults, although normal values vary according to age. Pulse oximetry. Pulse oximetry is a tool which non-invasively measures arterial oxyhemoglobin, giving a percentage value for oxygen saturation. The relative inaccuracy of these machines, that is, their unreliability in reflecting arterial oxygenations, means they cannot be used as the only method of monitoring oxygen in the critically ill infant. They are, however, useful in terms of monitoring trends of change in arterial oxygenation in acutely ill infants and children. Transcutaneous oxygen monitors. Most medical units use transcutaneous oxygen monitors to give an indication of oxygenation. These monitors provide a non-invasive means of measuring the partial pressure of oxygen in arterialized capillaries through the skin. Transcutaneous oxygen monitors have electrodes which are heated and placed on an area of thin skin, example abdomen. The heating produces a superficial erythema so that the PO2 in the dilated capillaries can be assessed by the machine and placed on a visual monitor. Normal values are 8 to 12 kPa, 60 to 90 mHg. Accuracy is checked by regularly comparing with arterial blood gases. Electrodes need to be moved to a different position every 4 hours in order to prevent burning. In order to remain accurate, the electrodes need careful positioning and calibration. Carbon dioxide monitoring. When necessary, it is possible to monitor CO2 levels either transcutaneously or using end tidal monitoring. Respiratory support. Oxygen therapy. Supplemental oxygen therapy for the treatment of hypoxia may be administered by several means and is discussed in detail in Chapter 8. However, there are important points to consider when administering oxygen therapy to infants and children. Oxygen can be delivered directly into incubator via an inlet, but it should be noted that such delivery can rarely exceed an FiO of 0.4. Head box oxygen delivery via a deer plastic box placed over an infant's head is a very effective means of delivering supplemental oxygen, and FiO2 levels of up to 0.95 can be effectively achieved. If used with small infants, the humidification of inspired gas should be warmed. Other means include pharyngeal catheter inserted UCM or paid TNC nasal cannulae, which can achieve an FiO of 0.5 with a flow of 61 per minute. Older children are more able to tolerate a face mask or a nasal cannula. Humidified oxygen delivered via a head box. Humidification of inspired air is essential for infants and children as narrow bore endotracheal tubes (ETT) and small caliber airways can easily be blocked by thick secretions. Children requiring ventilation usually have a heated humidifier as a part of the ventilator circuit. The amount of humidity received by the child is dependent upon the temperature of the humidifier, ambient room and or incubated temperature, gas flow rate, level of water in the humidifier chamber, the length of ventilator tubing, and the position of the temperature probe in the ventilator circuit. The optimum temperature of the inspired gas is unknown, but temperatures greater than 36.5 degrees Celsius have been shown to reduce the incidence of chronic lung disease in infants weighing less than 1,500 grams. Nitric oxide. Nitric oxide is a gas at room temperature which can be used to reduce pulmonary arterial pressures but has no effect on systemic pressure. It is delivered directly to the lungs during artificial ventilation and can be effectively used to treat pulmonary hypertension in infants and children. Continuous positive airway pressure (CPAP). CPAP, Chapter 5 and Chapter 6, may be used as a first-line treatment in infants and children requiring respiratory support or as a part of the process of weaning from full ventilation. CPAP may be applied via an endotracheal tube or in non-intubated infants via a face mask or nasal prong. Endotracheal intubation. Indications for endotracheal intubation are maintenance of patient's airway, protection of the airway in states of altered consciousness, facilitation of pulmonary toilet, and for mechanical ventilation due to inadequate spontaneous ventilation. Tubes may be nasal or oral, and in children below 8 years of age should be uncuffed to reduce the risk of damage to the tracheal mucosa and subsequent stenosis. It is important that a small air leak exists between the tracheal tissue and ET1 to prevent mucosal damage. However, this does mean that the potential for aspiration is greater. Conventional mechanical ventilation. A variety of mechanical ventilators are used in neonatal and pediatric practice. Pressure-limited ventilators avoid excessive inflating pressures and reduce the risk of barotrauma. There is a continuous flow of gas around the circuit which allows the infant to breathe spontaneously between ventilator breaths. However, if lung compliance decreases acutely, example secretion accumulation, the tidal volume delivered will fall. This may go unnoticed as the ventilator continues to cycle at the preset pressure, and close monitoring is therefore essential. Time cycling allows the ratio of the inspiration to expiration to be controlled. Nasal intubation, oral intubation of preterm infant. Volume cycled, pressure limited ventilators deliver a preset tidal volume and are effective in situations where airway compliance is low and resistance is high. However, this can result in the delivery of excessively high inflation pressures which increase the risk of intrathoracic air leak and barotrauma. The use of PEEP is standard when mechanically ventilating infants and children to prevent airway closure at end expiration, as closing volume is much closer to FRC. Patient-triggered ventilation has been shown to be useful as an aid to weaning from conventional ventilation and in some mature infants during the acute stage of respiratory distress syndrome. It is not useful as in the very preterm low birth weight infants whose respiratory efforts are often inadequate and inconsistent. Modified neonatal ventilators that respond quickly to small changes in airflow are needed in these infants. In the newborn, ventilation is often started from birth in infants of birth weight less than 1000 gram, but otherwise the indications are deteriorating blood gases indicating respiratory failure, that is PaO2 less than 8 kPa, 60 mmHg, with an FiO2 of 60% and or PaSO2 of greater than 8 kPa 60 mmHg. Recurrent or major apnea, major surgery pre and or post operatively, example cardiac lesions, diaphragmatic hernia. Preterm low birth weight infants have been shown to be better oxygenated with fast rates of ventilation, 60 to 150 breaths per minute, using time cycled pressure limited devices. This seems to allow the infant to synchronize with the ventilator and thus reduce the occurrence of pneumothoraxis. If synchrony cannot be achieved, it is necessary to use paralyzing agents when ventilating these infants. Weaning from ventilation in infants and small children is achieved by initial reduction of the inspiratory pressures and the inspired oxygen concentration. Intermittent mandatory ventilation (IMV) can then be used, followed by CPAP. Extubation is usually performed from CPAP via the ETT, but some infants require a period of support on CPAP via nasopharyngeal airway nasal prong prior to unsupported spontaneous breathing. The weaning process in older children is similar to that in adults. Negative extrathoracic pressure ventilation. Negative extrathoracic pressure ventilation (NEPV) was first used in the treatment of children with respiratory failure due to poliomyelitis. It has now been adapted for use in the management of respiratory failure due to a variety of causes, though its use is at present not widespread. The equipment consists of a transparent perspex box in which the infant's body is placed with the head remaining outside. An airtight seal around the neck is essential. There are portholes for access for nursing care and physiotherapy. A negative pressure is applied to the box so that the pressure inside becomes subatmospheric and assists with ventilation. It can also be applied via rigid thoracic jacket, example Hayek jacket or cuirass shell. The indications for the use of NEPV are respiratory failure due to myopathy or other neuromuscular disorder, congenital central hyperventilation on Dine's course, bilateral phrenic nerve damage, weaning from positive pressure ventilation, example in RDS or following cardiac surgery, prevention of further lung damage due to positive pressure ventilation in infants with severe chronic lung disease. High frequency ventilation using either jet, HFJV, or oscillatory ventilation, HFO, employs small tidal volumes, less than anatomical dead space, and high respiratory rates, 60 to 3000 per minute, to achieve adequate ventilation. High velocity ventilation result in increased mixing, gas diffusion, and exchange. In theory, ventilation is more evenly distributed while the airway pressures used are lower. High frequency oscillation has been shown to be safe and effective in the treatment of respiratory failure in pediatric practice. The response to HFO in terms of improvement of oxygenation is also helpful in predicting outcome in children with potentially reversible lung disease and severe acute respiratory failure. Extracorporeal membrane oxygenation. Extracorporeal membrane oxygenation is a technique which oxygenates blood outside the body and, if necessary, can also provide cardiovascular support for a limited period of time during which the underlying pulmonary disorder is expected to recover. It has been reported to be beneficial in some children with acute lung injury, and more recently, a collaborative randomized trial of neonatal ECMO reported it to be clinically effective and a therapy which should be considered for neonates with severe but potentially reversible respiratory failure. Liquid ventilation. It has been suggested that the use of liquid ventilation can improve ventilation perfusion mismatch by promoting a more even distribution of pulmonary blood flow and improvement of compliance through the elimination of the gas-liquid interface. It may also be less damaging to the lungs when compared to gas ventilation. Ventilation using liquid perfluorocarbons has been reported as successful in infants and children with severe respiratory failure. Complications of ventilatory support. Pneumothorax. Pneumothoraces are a complication of positive pressure ventilation occurring mainly in preterm infants with immature lungs or in association with congenital bullae. A predisposing factor is the hyperinflation of alveoli occurring in conditions such as meconium aspiration and respiratory distress syndrome (RDS). They are also a complication seen in older children whose lung compliance is very poor and who require high inflation pressures. Causative factors are high peak inspiratory pressures, positive end expiratory pressure, long inflation times, and active expiration by the infant against the ventilator's inspiration. Attention pneumothorax will cause a sudden deterioration and should be drained as soon as possible with chest drain and suction. Small pneumothoraces may not require drainage, but the infant will need close monitoring. Pulmonary interstitial emphysema. Pulmonary interstitial emphysema occurs when gas leaks out of an alveolus, tracks along the cardiovascular bundle, and remains trapped, forming interstitial gas pockets. PIE is most common in preterm infants. The incidence is inversely proportional to gestational age. Treatment is fast rate, low pressure ventilation with a longer expiratory than inspiratory time to prevent an increase in air trapping. In severe cases where ventilation is becoming difficult, needle sacrification of the lung surface may be helpful. Unresolved PIE may require surgical resection in severe cases. Subglottic stenosis. Subglottic stenosis occurs in some infants following prolonged intubation and leads to upper airway obstruction. It should be avoidable by attention to tracheal tube placement and fixation and care with suction. Acquired neonatal tracheobronchial stenosis, particularly in preterm infants, has a poor outcome. Stridor is often present and may respond to adrenaline via a nebulizer. In more severe cases, a tracheostomy may be necessary until the airway has increased sufficiently in size to allow adequate ventilation. Some patients will also require surgical laryngotracheoplasty before successful decannulation of the tracheostomy can be achieved. More recently, primary repair of subglottic stenosis with laryngotracheal reconstruction has been performed and can be effective. This condition of preterm infants is seen when the delicate capillaries in the retina proliferate, leading to hemorrhage, fibrosis, and scarring. In the most severe form, this may result in permanent visual impairment. The cause is unknown, but periods of hyperoxia, exact length of time unknown, with a PaO2 of about 12 kPa are thought to be a major predisposing factor. Careful oxygenation, monitoring, preferably using an arterial catheter, is essential to attempt to prevent this condition. The damaged retina is treated with cryotherapy. Chronic lung disease. Chronic lung disease is defined as a requirement for ventilator support at 1 month of age. Infants with severest form who have specific radiographic changes are said to have bronchopulmonary dysplasia. The incidence of CLE varies between 4% and 40% according to initial respiratory illness, birth weight, and gestational age at delivery. It is more common in preterm infants who have had acute RDS requiring oxygenation, oxygen, and ventilatory support. High peak pressures and positive pressure ventilation cause barotrauma, and high inspired oxygen concentrations cause an acute inflammatory response leading to local tissue damage. Other precipitating factors are fluid overload, persistent ductus arteriosus, PIE, and infection. The infant with CLD shows an increased oxygen requirement and carbon dioxide retention and has decreased lung compliance with increased airway resistance. The infant is tachypnic when with persistent sternal and costal recession. The condition may be progressive, requiring more ventilatory support and eventually leading to respiratory and cardiac failure. Radiographic appearances can vary but include alternating areas of collapse and hyperinflation, widespread fibrosis, and scarring of the lung with compensatory emphysema. Treatment consists of appropriate respiratory support, which may be IMV, CPAP, HVO, HFO, NEPV, or added oxygen via headbox or nasal cannulae. Good nutrition is essential, and the infant may require fluid restriction and diuretics. Some infants respond to bronchodilators and steroids. Antibiotics may be required as these infants are prone to recurrent chest infections. The prognosis is variable. Mortality may be high as 40% in severe cases. Those who survive are often small and underweight, have recurrent upper and lower respiratory tract infections, wheezing, and gastric reflux. Some children may require oxygen for several years and are therefore managed at home if the family is able to cope with home oxygen therapy. The long-term prognosis for those who survive the first 2 years is good. Physiotherapy. As infants with CLE are particularly prone to chest infections, physiotherapy may be indicated if excess secretions are a problem. These infants often have severe wheeze and airway collapse, and physiotherapy techniques may not be appropriate. Careful assessment is important before any intervention. If wheezing is not too severe, careful treatment may be possible following bronchodilator therapy, providing the infant has a good response. Modified gravity-assisted positions with chest percussion may be useful, and suction may be required. Infants having oxygen through nasal cannulae often have a problem with thick, dry nasal secretions. It is not possible to humidify oxygen effectively when using nasal cannulae, as the water condenses in the small bore tubing and cuts off the oxygen supply. Humidifiers which bubble oxygen through cold water counteract the absolute dryness of oxygen to some extent, but are not effective in loosening thick secretions. If necessary, the infant should have nasal cannulae while awaking during the day to allow social interaction, but should have humidified oxygen via a head box for long periods of sleep. Normal saline via a nebulizer or saline nose drops can also be used, but have a limited effect.